Greetings from Dr. Sadhana Gupta, and I welcome you all for this dialogue and the discourse on management of postpartum hemorrhage. It is about me, and I seek everybody's blessings, good wishes, and support for my forthcoming FOGSI presidential candidate election year 2023. And I have served selflessly FOGSI at national and international platform since 30 years. So a big gratitude for always being together for so many programs, for so many projects and the publication. And we look forward to a great journey ahead. I bring greeting from land of Buddha and eternal ascetic Gorakhnathji, who says we can never obtain peace in the outer world until we make peace with ourselves. So, what is postpartum hemorrhage? Its magnitude and impact on everybody's life. We lose around 150,000 mothers worldwide due to obstetrical hemorrhage, and the postpartum hemorrhage contributing to around 25 to 30% of all maternal death worldwide. And it is a matter of great concern that Africa, Asia, and India constitute major proportion of maternal death due to postpartum hemorrhage. What is the clinician perspective? How we obstetricians see postpartum hemorrhage in our day-to-day practice? We are bound to face it in around 2 to 10% of all deliveries, and out of them, 1 by 1,000 can be massive and life-threatening. Obstetrical hysterectomy, admission to ICU, massive blood transfusion, which is needed for the management of severe postpartum hemorrhage, constitute in the category of near-miss maternal mortality, and it is a cause of long-term severe morbidity like severe anemia. And women who survive severe PPH are significantly more likely to die in year following postpartum hemorrhage. So when India boasts of having the third largest economy of the world, PPH is contributing to around 35 to 56% of maternal death in India. Postpartum hemorrhage tests functioning of our health system. It tests our skill, our guts, and our leadership at this moment, because it is often unpredicted and presents like a thunderbolt. We have the basic classical causes, we have the new causes, but the important thing that we can lose patient very rapidly in a short span of 1 to 2 hours if we don't take very, very stepwise and the coordinated action. So in India, we are having all age-old problem, a lot of anemia prevalence in the women of reproductive age, 3 delays, access to quality obstetrical care, safe delivery place, and a very sound referral system. And we have all the new challenges, which is increased number of cesarean section, all placenta accreta spectrum, and a rapid change in the obstetrical demographic, like we are facing the women with myomas, obesities, medical comorbidities, underage, and the coagulopathies. So as an obstetrician and gynecologist, we have to be ready with all the knowledge and the skill update so that we can save these mothers and prevent the preventable mortality. So why we have collected there? Because we want to prevent life-threatening PPH. We want to improve a clear decision-making base when there is a chaos, confusion, and complexity. Because if you save the mother with PPH, it is morally boosting. While if we lose the PPH or critical illness, we had a long-lasting demoralization impact of the leading obstetrician and hospital team. So if we don't manage the PPH in a coordinated, clear way and the suboptimally, it can threaten the well-being of not only mother but also neonate family and obstetrician, because it has potential medico-legal, media, and social issues. So we have to be very alert and readiness in all points. So here we are, because our government is doing a lot for the healthcare system, and now we have good roads, we have the ambulance, we have the road ambulance, water ambulance, even the air ambulance. But it is our responsibility that when the patient reaches to our hospital, we must be equipped with the trained, adequate personnel, human resources, equipment, drugs, and the ready availability of all second line and the third line measures. So coming one by one, so can we prevent the postpartum hemorrhage? It is $1 million question. Yes, we can do a lot in prevention of postpartum hemorrhage, and the issue starts right in our busy OPD practice. Always for all pregnant women, take a adequate history of postpartum hemorrhage in previous delivery. What is the placental location? If there is multiple pregnancy, if there is any high risk factor like grand multiparity or the preeclampsia, or women taking any anticoagulant or having any coagulopathy. But what next? As a expert obstetrician, you are aware of these risk factors. But patient can go to any center for delivery in emergency situation or in any or other emergency cases. So what you have to do when you have identified the high risk factor for PPH, flash a antenatal card with the red pen. Always counsel family that this patient has the risk of the postpartum hemorrhage and you might be needing the blood donor and the money, and you have to make a plan for the delivery at the right place where all the facilities are there, and sensitize all labor room staff that when these are any flash card red flag sign on antenatal card, that you must call the senior obstetrician and do all preventive measures. So the second step is the active management of third stage of labor, and from 1988 we have come a long way. Now there are four arms of the active management of third stage of labor, but the most important and the crucial arm is oxytocin agent administration within 1 minute of birth of baby. The rest are late clamping of cord because of baby's benefit, controlled contraction with a bar that a skilled birth attendant should be there who knows how to do the controlled contraction, and now uterine massage is not recommended for active management of third stage of labor. Benefits of active management of third stage of labor are immense. It reduces third stage duration, risk of postpartum hemorrhage, risk of severe PPH, need for the blood transfusion, decreased risk of anemia, and decreased need for additional uprotonic medication. And now with the late clamping of cord, it is advantageous for the baby also. So what oxytocin agent at what time? So till now, oxytocin is the drug 10 unit intramuscular or 10 unit in the IV, ringer lactate and the crystalloid as a active management of third stage of labor is a very good choice, because there is no contraindication for use of oxytocin, and it has no effect in any important effect on the maternal water, and there is no nausea and the vomiting. Misoprostol, our many obstetricians and gynecologists are using, but I want to emphasize that it is a second choice for the active management of third stage of labor, and you have to give either orally or sublingually to make it effective into the laboring woman. The side effects can be shivering, vomiting, diarrhea, yet it is useful when there is a no facility for the injection and it is in the community setting, or sometimes when there is a issue of any injection or the lack of health personnel. So all professional bodies strongly recommend the use of a uprotonic agent as the active management of third stage of the labor. Now we have a paradigm shift in the MTSL, and now we have the carbetocin, which is a long-acting oxytocin with a very strong affinity to oxytocin receptor. So, and many preparations are room stable at the room temperature, that is around 2 to 30 degrees centigrade, and it has the additional function to thicken the blood, so it further prevents PPH. So our country and our obstetrician have waited a long for availability of such drug, which is so very useful in all resource setting, and it came to our country just 1.5 years ago after the champion trial, where India contributed a very significant way in the trial. An important caution, it is to be used as a single dose or only. So I want to give this message that never repeat carbetocin, because it has got a very strong affinity to oxytocin receptor. Always to be given after delivery of infant. It is never and never for any induction. And the carbetocin should be used either as the active management of third stage of labor, or if it is not be used as a MTSL, then it is also a drug for the management of postpartum hemorrhage. Maximum studies have been done in the cesarean delivery, that is 100 microgram 1 ml to be administered in the 1 minute. However, in vaginal delivery, it is as effective, and I am using very regularly carbetocin in my all delivery, cesarean or the vaginal delivery. What is the added advantage of carbetocin? That it eliminates requirement for an infusion after initial dose. So especially when woman is anemic, she is having preeclampsia, when we does not want the fluid overload which we give for the oxytocin continued drip in post-operative period, that continued need of the oxytocin is totally eliminated with the use of carbetocin as active management of third stage of labor. So, however, we have a wonderful drugs. We have oxytocin, we have carbetocin, we have misoprostol also in certain settings. But important thing is that they must be available near the laboring woman in our labor room, in the fridge, so that a good cold chain provision is there and availability of a good skilled but attendant who know when to do, how to do the active management of third stage of labor. And it is our duty that we always monitor the number of women which is receiving protocol based care. So this is very important that this in my journey of FOGSI, I have done a lot of things for active management of third stage of labor because in 2011-12, oxytocin was being kept in the Almira and the shelf in the pharmacy. And after Path Oxytocin initiative and project, for whom I was coordinator. After that, we made a campaign that the oxytocin should be right from the manufacturing to the retail shop. It should be kept into the fridge and the universal following of active management of third stage of labor. As in Dr. Hema Divakar's presidential year, we did a lot of helping mother survive program. Now, the more you sweat in peace, the less you bled in war. Yet, we are going to face the PPH in unpredictable situation at any moment, and we have to be ready with our fire drills. Why do we lose mothers? Because we lose the golden hours opportunity. We have a little delay in correction of hypovolemia, and we have a delay in control of bleeding. And here are the points where we have to act very, very aggressively. So, how to resuscitate and medical manage? First of all, make a strict protocol that every laboring woman or every woman after cesarean section is vigilantly followed in golden hour, that is 2 hours after delivery, where there must be the skilled nursing staff who is looking for bleeding PV, tone and height of uterus, pulse blood pressure, what is the level of consciousness and the respiratory pattern and oxygen saturation. So for this, we must have the cardiac monitor not only in our operation theater but in our surgical post-operative care as well as in our labor room, because labor rooms are heavy, sometimes the staff is overburdened, and when they have the cardiac monitor backup, they are much less going to miss the postpartum hemorrhage, and they are much less going to have the like missing the resuscitation in the golden hour. So after that PPH, it can present to us as a primary as well as secondary within first 24 hour or after 24 hour. But when as a senior obstetrician gynecologist, you are called for handling the situation, first make a quick 360-degree review while you are doing resuscitation and starting initial management. The cause analysis is very, very important, which is expected from a senior obstetrician and gynecologist. We have the classical cause, tone, tissue, trauma, thrombin, and as obstetrician gynecologists, we all know it. But important thing is in the cause analysis that you have to make very quick analysis that what type of hemorrhage or what the multiple causes of hemorrhage I am dealing in this particular patient. If the patient had prolonged labor, induced labor, chorioamnitis, use of GA, patient can have the atony. If the patient is having fibroid, it can cause to the again atony and traumatic. And if there has been a difficult delivery or the precipitate labor, patient can have the uterine inversion. Difficulty from when the placenta is liable to retain or difficulty in retained placenta, then if there is a difficult delivery, then the trauma can be there. And if there is any predisposing situation like preeclampsia, amniotic fluid embolus, use of heparin and aspirin, then you have to look for the coagulopathy. So it is a cause analysis. It is just not cramming or knowing multiple cause, but it is a cause analysis which is very, very important. And the atony constitute around 70%. But yes, coagulopathy is still in our way because we are having a lot of comorbidity, and there can be multiple cause of postpartum hemorrhage, like from leading to infection, leading to atony, use of tocolytic, and chances of removal for the placenta. So trauma, tone, sepsis, everything can be adding to the cause of postpartum hemorrhage. Now, how you diagnose if it is there PPH and what is the severity of PPH? Because accordingly you will direct the management. Why we lose the opportunity to diagnose the PPH? Because nature has been kind enough to make the pregnant woman hypervolemic. So they withstand the initial loss of 400 to 500 and their vitals are not changed. So at that time, we have to be very, very careful, and postpartum women monitoring for the vitals and for the bleeding per vaginal should not be left to the unskilled person, because the visible estimation of blood loss is notoriously inaccurate. But if there is a constant seepage of the blood, if there is a 5 normal size pad, and you can use the Devdas bag and the Chhattisgarh rib or Chhattisgarh bag also, so that you can have a quantitative estimation of the blood loss. So give clear instruction to your labor room if this sort of bleeding is there, if you are continuously trickling of blood, if the patient has soaked her bag or the floor, it is time that you have to call the very, very senior person. That if there is PPH, you need several pairs of hands and brain. So always call your friend, and it should not be a random calling to call, but it should be a very focused call. That is your believable anesthetist, senior nurse, obstetrician colleague, smartest ward boy and the eyes and theatre staff, and inform blood bank person that we are having a patient with the postpartum hemorrhage. Assess what is the level of hemorrhage and assess the cause analysis and the severity of hemorrhage. How we can do it? It is the pulse blood pressure. So it is pulse going up, blood pressure going down, urinary output is less, capillary refill sign is delayed. Then you can categorize that how much amount of blood patient has lost, and the shock index has come to rescue, which is very, very simple thing. And if it is more than 0.9, it indicates sign of shock. But again, you have to have the cardiac monitors in your labor room. So simple estimation of heart rate and systolic blood pressure gives you fair idea that what is the severity of hemorrhage. It is minor, moderate, or the compensated, or the major. It is a golden rule of 30, we all know, and all this sum up in our reflex estimation that what amount of hemorrhage we are dealing with. Our labor rooms, our cesarean OT must be set 24/7 with all availability of drug, oxygen cylinder with its key airways, all emergency trays for PPH, chart for PPH management, and contact number of all the required friends in our intercom and in our mobile number. So when you are dealing with the postpartum hemorrhage, the basic start thing, replacing crystalloid. When you are putting intracath, it should always be green or gray. At the same time, take the blood from grouping and case matching and all other investigation, record, event, and communicate. So this is the basic. Even the hemorrhage is low, and you think that you can deal with it. Yet this is the minimum, because we never know that which patient is going to go into that way. But if it is a moderate to severe hemorrhage, then we have to have the full protocol of measure to resuscitate, monitor, and arrest the bleeding. And it is vital that never scold your nurses or the junior resident that why you called me, patient is fine, because otherwise next day when there will be real problem, they will be fearful to call you, and because it is like a loss of face. So this is also, the non-technical things are also very, very important. So when a moderate to severe hemorrhage, assess airway, always give oxygen irrespective of oxygen saturation. And what I emphasize, there should be no place for the pink cannula in neighborhood, always green and gray cannula. Make position, keep the patient warm, keep the patient flat. Give, if you have not given, give carbetocin and oxytocin, and assess need for blood transfusion, always catheterize. In a situation like placenta perfida spectrum, sometimes we have a severe hemorrhage within few minutes. And for this, we must be knowing the skill of doing how to do the bimanual compression, how to do the aortic compression. So this is also very, very important in today's scenario. So resuscitate, investigate, monitor, communicate, and record keeping, and arrest hemorrhage. When you are putting intracath, you must have in your PPH box not only the drugs and other things, but also the 3 plain vial, 3 EDTA, and the 3 citrated vials, so that you can send the blood for cross matching, for the all renal liver function test, for the coagulation profile, prothrombin time, fibrinogen, and the D-dimer. Because when the patient blood pressure is low, sometimes it is so difficult to get the second entry. So what is the PPH care bundle? WHO, FOGSI, and our professional organization strongly implement, and as a FOGSI presidential candidate, this is my vision, that universal following of the maternal care bundles to reduce maternal criticality and the mortality. So what are the bundles? It is a selection of guidelines and recommendations in a joint form, which is systematically, if implemented, it results into a good outcome for the patient. So what is the PPH bundle? It is utrotonic drug, crystalloid, tranexamic acid, and the uterine measure. And if it is not responding, then coming to the second step measure. So chart for health, cannula, oxygen, and a good number of the crystalloid. So you must have the ringer lactate or normal saline, right? 3 or 4 points always in the emergency crash tray. And crystalloid, why these are the fluid of choice? Because they don't stay into the intravascular space. They are rapidly accumulated, so there is a less chance of the pulmonary edema, and they don't interact with the coagulation test. And if you think it is a 1 liter loss of the blood, then you should give the around 3 liter of the ringer lactate or normal saline to the preferably the ringer lactate to the woman. And the crystalloid is the fluid of choice. Colloid, many people start right as soon as there is a blood pressure drop, they start Hemexil now, Hemexil, give Hemexil. So this is very important that colloid is our second choice. And when you have given around 2 to 3 liter of crystalloid and the blood component is not available and patient is bleeding, at this moment for a short gap up, you can give the colloid around 2 point, that is around 1500 ml. The third question is always when you have gave what is the 360-degree view, always look placenta is delivered or not and if it is complete or not. And for this, you must give the instruction to your staff that placenta is never thrown away unless and until the golden hour 2 period 2 hour has been passed. Because sometimes patients bleed after 1 hour and you want to look for the placenta and it has been thrown away. So this is very important. And today's time, this is very important also that if there is a suspicion of placenta accreta spectrum disorder, then never and never try to remove the placenta. This is the basic teaching. When you have the bleeding, you have to remove the blood clot from vagina. You have to do the fundal massage with the simple round circular movement, because if there are blood clot in vagina and uterus, that themselves will cause atony and that will add to the atonic postpartum hemorrhage. What drugs we have? So oxytocin, carbetocin, we have been taking care. Then the methyl ergometrin, misoprostol, and PGF2 alpha are the drugs which are available for the atonic PPH. So all these drugs we know, we use day in and day out. It is important that we have the optimizing of all uterotonic agents. So methyl ergometrin 0.5 milligram, always exclude the contraindication, that is anemia, hypertension, or heart disease. When you can have the syntocinon and ergometrin both, that is called symptometrin. If the second drug is the prostodin F2 alpha, the contraindication is bronchial asthma. Again, it has to be stored well. An important thing is that if one drug is not effective, then the second or third drug might be effective because the oxytocin receptor are different. And one drug is it is not causing the gaining of uterine contraction. The other drug can be having very, very good beneficial effect. So we have to be ready with availability of all drugs. The second thing is the good dosage. So don't think that if you are given injection ergometrin 1 and then you are not going any second drug ampule of the ergometrin. So I want to give this message that ergometrin can be given 4 doses, oxytocin around 40 to 100 units, misoprostol you can give 600 to 800 microgram, and PGF2 alpha you can give maximum 8 doses. However, if you have given 3 doses at this moment, there is again a chance, a time to review that whether the second degree measures are needed or not. Tranexamic acid has come after the women trial, and I am fortunate enough when these studies have been done and presented at FIFO and the FOGSI that I was also part of them. And tranexamic acid, that women trial showed that if the tranexamic acid is given in the first 3 hours of the PPH, the criticality and mortality is reduced. So WHO recommends that tranexamic acid should be given prophylactically to high risk cases and within 3 hours, and it should be repeated within 3 hours. After 3 hours, it is not going to be effective and it might cause a little bit harm. A word of caution that tranexamic acid is ampule looks same as the bupivacaine, and there have been reports. It is an anesthetic paper from the anesthetic journal, and it is a recent paper which shows that they warn that the potential side effect and accidental fatal intrathecal delivery of tranexamic acid. And in our country also, we have few cases in the National Medical Council where the criticality and mortality has been produced. So always keep a magnifying glass in your OT, because few injections look alike, and in some time hurry or a big load of the patient, any human can do the error. When to think for the blood transfusion? If you have the moderate to severe PPH, hemoglobin less than 7 grams, always have the HemoQ and the blood glucometer in your neighborhood so that we can have instant identification that what we are dealing with. If we have hemoglobin 10 gram, 9 gram, we have a little breathing space. But if it is a 5 gram, 6 gram, then this is the time that we have to organize for the blood transfusion. Always look for the antecedent cause for the coagulopathy, that is IUFT, T-severe preeclampsia, placental abruptio, or amniotic fluid embolus, which can result into the coagulopathy. Our bedside tests, which were our teachers taught us, bleeding time, clotting time, clot observation. I and Donald beautifully described it. Are they obsolete in today's time? No, they are not obsolete. Any resident can do very, very nicely. It is simple collection, taking the blood in a simple test tube. Take it that in 20 to 30 minutes, clot is formed. Rotate the tube and you see that a strong clot is formed or the clot is thriving, and it gives you very, very accurate like estimation of what is the fibrinogen level. Our own Dr. Nalini Mishra has produced a beautiful paper which has been published in FIGO, who says very, very correctly that this bedside test gives you a fair idea of the fibrinogen level when you start massive transfusion protocol. So I want to wish one important message that only after 3 to 4 units of PRBC, the active massive transfusion protocol is start. That is 1:1:1 or 2:1:1. So it is not right from the very beginning that you start 1:1:1. After 3 units of PRBC, their patient is still bleeding or you are suspecting coagulopathy by bedside and the coagulation profile. This is time then we start with the massive transfusion protocol. What we want to achieve: hemoglobin more than 8, platelet count 70 like 5 lakh, more than prothrombin 1.5, and we want to have the stable vitals as well as the good patient temperature. Always be ready with all PPH phase, drug availability, instrument in our Manyata session. We are accurately actually training every skilled birth attendant that they must be having all the trays ready and always record the parameters, event, what treatment has been given, and whatever is the situation, we have to communicate, allocate some senior compassionate person who can communicate with the woman attendant and colleague, because it is a potentially medical legal situation. So it is about Manyata, what we say, join Manyata program so that your skilled labor room staff is confident enough to deal with this PPH. Always cause analysis, and when there is a cause, you have to treat it like retained placenta, look for MRP, laceration, uterine, cervical, look for the tear, and that is the repair of the tear. Conservative surgical measures, it is a basic classical teaching, bimanual uterine compression. So thumbs up, put the knuckles in the anterior fornix. Actually, we know it. Important thing that our all staff must be very much versed with the regular drill that how to do. Samartha is one of the innovators from the cannula, and his cannula works magically in the atonic PPH as well as sometimes traumatic PPH, because it is based on the physical principle of contraction and retraction. So it should be available in our labor room. When the patient to be shifted from labor room to OT, what you want to assess, so very, very quick analysis and response to treatment you have to assess. So when there is a cervical tear, vaginal tear, shift the patient into OT, good anesthesia, good assistant. You have to be ready with all suture material, because sometimes you like a variety of suture from 2-0 to 1, and from catgut to the vicary you have to need, and the add-on things like a cotton catheter. So the principle of cervical tear repair has to be followed very, very religiously. One of the inspiring figure of our country is Dr. B.P. Pally, and he has innovated a beautiful transvaginal uterine artery clamp. From vaginal root, you can clamp the uterine artery. It is very simple and effective. Meanwhile, you are transferring the patient from primary, from the low resource to high resource setting, from labor room to OT, and sometimes it actually corrects itself. So a wonderful paper from Dr. D.P. Pally that how this transvaginal uterine artery clamp is effective. Balloon tympanoid, we have a costly battery balloon tympanoid, but we can make it right on the stop, Chhattisgarh, easy balloon, so that we can make it. And always be aware of retained placenta, placental piece. So always look for placenta, whether it is properly delivered or not, and mobilize the team for the manual removal of placenta at right time with a good skill, again retained. Because I do not rightly say the real difficult part about MRP is the decision to undertake it. Always look for the coagulopathy, and what I emphasize that the obstetrical situation which can cause coagulopathy, and there is a lot of knowledge gap, and we look forward to further educational issues that our all obstetrician and gynecologists have the good knowledge for the coagulopathy. When it is time to open up in PPH or reopen in PPH after cesarean section, when you find totally flabby legs, uterus pouring blood, you are not able to suture the high cervical tear or the wall tear, that is the supralevator injuries, indefinite contour of uterus, you are feeling that it is a postpartum uterine dehiscence, or the lump abdominally pointing to broad ligament hematoma, increasing size, or the rupture of uterus. Take early and prompt decision, never delay it, and call urgently your team, that is two surgeons, senior anesthetist, staff nurse, and the blood bank. If patient very low, like always aortic compression, NASG is with us, and we have to be ready with all surgical measure that we are dealing with in the following session, revascularization, hysterectomy we have to develop. So finally, we have to save lives. Drastic situation need aggressive measure, set protocol, take swift by decision, get ready with your team, prepare team of friends. If you think that hysterectomy is needed, do it at the right time, and a sharp eye on potentially medico-legal issue by good communication. So it is PPH. If you can fill the unforgiving minute with 60-second burst of distance, with this, I seek your full-hearted support for my forthcoming FOGSI presidential candidate. I am ready with my vision and approach and the following of maternal care bundle all over India, and having the positive, promotive, and protective FOGSI is my theme. Please remember to vote for me. Ask all your friends to vote for me from 1st August to 10th August 2023. Thank you very much for the patient listening.